in the light of what I had told you in the last class, this is what my last slide was, and basis of which I started, my endocrinology lectures. So in my last class, you saw that we talked about hypothalamus, and we were starting off with pituitary. And there's so many hormones in pituitary, which I wanted to tell you about. We covered oxytocin, vasopressin, growth hormone, and prolactin in the last class. And from today's class, there's another milieu of so many other, end organ steroidal hormones, which is to be done. Like one of them happens to be estrogen progesterone interplay, because of which you have this, and of course testosterone, because of which you have the current ongoing topics. So now my topics are going to include, I'm not talking about LHFSH right now, because that will take my discussion to puberty. Probably if time allows, I'll be taking that topic up as well. So that topic has been already covered in my complete course. Those of you who already have my complete course with you do know that there is a topic covered properly as puberty. But if time allows, I'll go back to it as well. At the same time, menopause. So FSH and LH, puberty, menopause are the two lectures which are pending, and I would be taking them. Again, I'll take your viewpoint whether you really want those lectures or not. The second thing is, right now, I'm going to focus on the end organs. That is, I'm talking about ovaries and testicles, which are now secreting estrogen, progesterone. Of course, testosterone in females is secreted by a different mechanism. The theca cells, they produce these androgens. And the ovaries, they are producing estrogens and progesterone, and we'll understand the imbalance of these hormones finally leads on to this PCOS, which we were talking about. Then our next class will include adrenal cortex hormones, which include, your cortisols, aldosterone, and so many other, hormones, which are also again very important. And then, of course, thyroid hormone, there's going to be another class on. So we have a lot of lectures to go. Just imagine, endocrinology was a part which earlier on, even I thought, what is there to cover in it? There are very obvious 2-3 points which people might be knowing already. But once I started making lectures, I understood there's so much to cover in endocrinology alone. So let's not waste any further time. Let's go ahead and talk about PCOS. So when I talk about PCOS, what all things do they strike you about? First of all, you get a complaint of the patient with menstrual irregularities, right? Then you talk about hirsutism, unwanted hair growth at different parts of the body, chin, upper lip, abdomen, upper thighs, sometimes even arms. Then many of them, they come with subfertility, with anovulation, with disorders that, my cycles have always been irregular, and now I'm not able to conceive since the past 2.5 years of marriage. What is wrong with me? So these are a few symptomatology which a patient usually has when they are talking about PCOS. In a more scientific manner or on a more medical manner, these are the signs and symptoms. So what basically is PCOS, if anybody is to ask you? It's one of the endocrinological disorders, basically, which have repercussions on reproductive, metabolic, and psychological health. And the prevalence is as high as 8 to 13%, and all that depends upon the diagnostic criteria. So every patient who comes to you with a little bit of hirsutism, a little bit of delayed periods, and maybe subfertility or an ultrasound suggestive of PCOM, does not mean that she is necessarily a PCOM case or PCOS case. You have a certain diagnostic criteria which I'm going to be discussing later on. What are the main clinical features? So you have oligomenorrhea. The definition will be shared to you, because otherwise you do not really know what oligomenorrhea is. Excessive hair growth, again, we'll be discussing about it. Acne, weight gain, infertility, they are all, pretty subjective. Depression, long-term complications, which they are type 2 diabetes, hypertension, and increased risk of cardiovascular disease. Even this was asked in your examination. So the most important thing which has been discussed and asked in your exams, I don't know how many times, can't emphasize it any further. By now you already know these questions have been asked in exams. And please try to understand as I say, because I want you to take home 80% of my lecture today. If I'm going fast, please tell me to go slow. I'll go slow for you. But try to pick up as much as you can. I've tried to make it easier with slides, which will make you understand this whole etiopathogenesis better. So the most important etiopathogenesis of PCOS happens to be the insulin resistance. There is something in the body of the females who are destined to be PCOS, that there is insulin resistance inherently in their body. Okay, and insulin resistance proven that insulin resistance resultant hyperinsulinemia is observed in 50 to 70% patients, of PCOS. So there are lean PCOS patients and there are obese PCOS patients. So it's more, seen in the obese PCOS patients as compared to the lean PCOS patients. So, but there is definite insulin resistance. And what does this insulin resistance does? So there is hyperinsulinemia. I have made a slide. I think it will be a little easier for you to understand this. So because of this insulin resistance, there is hyperinsulinemia. And not only because of insulin resistance, there is some increase in basal secretion of insulin also, and there is a decreased hepatic clearance of insulin in patients with PCOS, because of which final result is more insulin in the body. Now, more insulin in the body, leads to what? It impairs the gluconeogenesis. Impaired inhibition of gluconeogenesis. Okay, and impaired what? The SHBG, this is sex hormone binding globulin production. So it decreases this SHBG production. So as a result of which, there is a lot of free testosterone in the body of the females. So there is some inherent amount of testosterone in a female's body. Do you know that? But at the same time, it's bound to serum sex hormone binding globulin, and it is acting at only those specific places where it's supposed to act. Otherwise, it's not left free in the bloodstream. But what happens in case of PCOS females is, because of whatever inherent insulin resistance or inherent metabolic disorder, this SHBG is left free because of decreased production, as a result of which a lot of testosterone is not bound to SHBGs because the production is low. And that leads to, and also there is inhibition of glucose transport in the adipocytes. So the free fatty acids also increase. Now the free fatty acids in turn, again, they cause insulin resistance, more, this vicious cycle. At the same point in time, you see that there is decreased glucose transport even in the muscles, and that decreases by 30 to 40%. As a result of all of this, there is increased glucose in the blood. Increased glucose in the blood also leads to more of insulin, but at the same time, this insulin is not able to act. There is hyperinsulinemia, but insulin is not able to do the basic thing which is supposed to do, that is utilization of glucose. It's not able to do that because there is resistance in all the peripheral organs. So what we get is basically just insulin in the body, which is not able to do its primary functions, doing all the others. It's decreasing the SHBG production. It's impairing the inhibition of gluconeogenesis. It's decreasing the glucose transport in adipocytes. So it's doing everything to increase, the metabolic syndrome even further. So this is one aspect of it. So I hope this is the slide that I wanted you to, take a screenshot, remember it, because this is a very nutshell in which you can write down. See, instead of this, if you just do this for an examiner, I'll be very happy. I'll give this student more marks as compared to this student. This is what I wanted to tell you. At the same time, here again, instead of reading, I have one more thing for you here, right? So I've made this slide for you. At the last time, I didn't have, time to make flow charts properly. So I just scribbled it down in the paper and try to present it for you so that you get a picture memory of this. Just in case my writing is not legible for you, you have these slides to help you. So I did not delete these slides as well. Now, so this increased insulin, it acts via the IGF-1 receptors on the theca cells. And what they do is that they've got two functions, okay? So they stimulate the testosterone and the androgens. And what happens is that, I told you, theca cells, they are the sites at which these androgens are formed. So they increase the stimulation, there's stimulation of production of testosterone and androgens, and they are the ones which are responsible for inhibiting the growth of the dominant follicle, because of which there is an ovulation in the PCOS females. Also, the increased insulin, what it does is that it stimulates the LH receptors, and they cause hyperplasia of the ovarian theca cells. Again, when there is a lot of hyperplasia of the ovarian theca cells, there are two things which are happening. Ovarian theca cells, when there's hyperplasia, they become more and more, they produce more and more testosterone and androgens. So there is more androgenic milieu of the ovary. At the same time, there's always a very thickened wall. If you see pearly white appearance of wall of the ovary in case of PCOS females, the reason is that there is a hyperplasia of these ovarian theca cells, and they form such a thick capsule of the the ovary that this ovarian milieu of the androgenic ovarian milieu it's confined in that space, and it increases more and more. And at the same time, even ovulation is not able to cut through that, strip off that, that thick wall. And most of the time they end up forming cysts. And these are not those small cysts that I'm talking about. These are those cysts which are not able to ovulate as well. Okay, so there is polycystic ovarian disorder because of the thick wall sometimes of the ovary, and because of which sometimes this ovarian drilling helps. Then there is one more thing, that this adipose tissue, okay, it gives rise to more of epiandrostenedione, right? And they finally form estrogen and inhibin, and again they go and stimulate what these LH receptors on the surface of theca cells, ovarian theca cells, as a result of which there is more and more of hyperplasia. So it's again a vicious cycle. Just remember these two slides, guys, and you'll be able to fetch marks in idiopathogenesis. Whether it comes for 5 marks or it comes for 8 marks, you are done. Because from here and here, this is there is not even one point that you've left PCOS idiopathogenesis. Okay. Now let's go on to the next hypothesis. That was one hypothesis. Okay. That hypothesis was based on insulin resistance, how insulin resistance is causing all these different problems, how insulin resistance is causing anovulation, how insulin resistance is causing hirsutism, how insulin resistance is causing different menstrual irregularities, because obviously there is anovulation, and how because of that it's causing subfertility. So you can make this flowchart, and at the same time, because there's no anovulation, you can write down different 2 spokes from there. The 2 spokes, one of them will say irregular menses and subfertility, both because of decreased or inhibition of ovulation. Then you come to the second hypothesis, which is the neuroendocrine hypothesis. Let's say, what does this talk about? So according to this hypothesis, it says there's a gradual increase in testosterone levels during puberty. They might gradually impair the daytime release of daytime GnRH by progesterone in girls destined to develop PCOS. That means for a girl who is destined to develop PCOS, what happens is there is increase in the level of testosterone. Okay, and that kind of inhibits GnRH. Okay, in the girls who are destined to develop PCOS. Now, what happens in these females, according to this hypothesis, that there is increased GnRH pulse frequency, and that favors the LH production over FSH production. Now, watch this carefully. Remember in my last class when I was talking to you, so many of you wanted to see my last class. Why? Because it definitely has its effect in the second class as well. Because I spoke in the last class about this level of GnRH pulse frequencies. I spoke to you that why when we're talking about this giving step up and step down protocols in ovulation induction, we try to mimic the natural level of GnRH pulse frequencies, because this is the level of GnRH pulse frequencies. It's low amplitude and fast. Every 1 hour this pulse is coming. Okay, slightly higher amplitude around ovulation, and then finally it gives the peak of LH surge, and then comes the ovulation. After ovulation, you just see that the frequency is somewhat delayed. The peak is now coming at every 3 to 4 hours. The amplitude is higher. Okay, so this is what happens in patients with PCOS, that this GnRH pulse frequency is maintained like this, like in the case of the proliferative phase, secretory phase, not the proliferative phase. So that is why the LH production is somehow favored as compared to the FSH production. And because this LH to FSH ratio has increased in PCOS, the relative FSH deficiency, it does what? It interferes with the granulosa cell aromatization of androgens to estrogens in the ovary, and that impairs the follicle maturation and causes anovulation. So obviously, because the milieu has changed, okay, when FSH should have been more, there is no FSH, there is more of LH, as a result of which the selection of the cohort of the follicles to develop, final maturation of the follicles to develop, it's not there, or it is disturbed, as a result of which there is chronic anovulation in case of PCOS female, or maybe 1 odd cycle of ovulation. At the same time, the increased LH pulse frequency induces the ovarian theca cells to produce more of androgens. So now you're kind of proving 2 things: how an ovulation takes place and why is there hirsutism. So more androgens, which makes GnRH pulse regulator more insensitive to progesterone, again causing further anovulation and increase in the level of androgens. I hope I'm clear here. Every time you have to prove 2 things: how and why hirsutism is there, and how and why anovulation, and subfertility is there. Then there is another hypothesis, the ovarian hypothesis. Then there is a low-grade systemic inflammation hypothesis, and then a couple of other factors. So if you write down this is almost a 10 marks question, looks like. So if there is a question which is asked just for 5 marks, do not write essay, which I have almost covered 5 slides in it. Okay, you will not have that much time to write for any question. Remember, guys, always remember that any question, if it's taking a lot of time, skip that question. Write down the important points, at some distance, and just leave that question, jump on to the next question. Once you finish the paper, come back to it. If you get time, write more lines about it. Otherwise, make sure that you've written at least that much, through which you get proper marks. Okay, suppose if a question is only for 5 marks and it asks you about etiopathogenesis of PCOS, that is also done. Okay, I'm telling you that DNB question papers mark distribution is very, stupid sometimes. I've made, this elaborate questions for 2 mark question. Why? Because I wanted to tell you that, it's that much to be written. But again, exercise your wisdom in your exams. There's no need to write that much. Okay, you have to, for 2 marks question, you have to write maximum, half a page. That's it, max, I said. So anyways, getting back to the point, now I'll tell you about the ovarian hypothesis. What exactly does that say? So it said that in the past, there was a primary defect in the ovary, which was destined to be, polycystic and secreted more of androgen, causing anovulation. So now it's known that it's secondary to insulin resistance and increased LH pulse frequency. So this theory, we do not take it any further. But yeah, that was one time it was thought that something is wrong with the ovary only of this patient, and there is thick wall in there, and there is because of anovulation is there. And now we know that actually because of other hormones, there is anovulation, not because of the ovary per se. Then we talk about low-grade systemic inflammation, okay, which is also seen. So various studies which are done on PCOS females, like I keep telling you, that it's a continuously studied branch, because every third female we see in our OPD is a PCOS case, especially those patients which come to us for infertility. So they say some studies, they say that there is always a low-grade chronic inflammation in PCOS, and that's evidenced by this people who studied PCOS people. They saw that there is more of CRP levels, more of interleukin-8 levels, TNF-alpha levels in these females. And there is some chronic inflammation which is continuously taking place in the females with PCOS. And because of which probably there is, insulin resistance, dyslipidemia, endothelial dysfunction. And we call this entire cluster of disorders as EXIN. Okay? Again, you can just write it down in the examination if it is asked, along with so many other things. Then we talk about certain other genetic factors. We know that it's got something to do with the genes. You see that in a family, if the mother has had PCOS, if she has had irregularity in menstrual disturbances, hirsutism, maybe she was not diagnosed by that time, but you see a similar thing in the siblings or at least one of the girls. Right? So it is 8 times more common in daughters of PCOS patients. There is also family history of type 2 diabetes mellitus in 80% of the relatives. So again, it tends to be multifactorial, polygenic. Remember these 2 buzzwords, write them down. Examiners will be very happy. Write down genetic factor theory. You also write down polygenic and multifactorial. They'll be very happy. Okay, some cases even having autosomal dominant inherited factors. And this CYP21 gene mutation has also been blamed in its etiology. So just remember, write down one of these words when you're writing down genetic factors. Remember to write down these 4 lines, that it's 8 times more common in daughters of PCOS patients. There's familial preponderance of type 2 diabetes mellitus in 80% of the relatives of patients with PCOS. It tends to be multifactorial polygenic disease, sometimes even having autosomal dominant factors in play, and CYP21 gene has also been blamed in the etiology. Of course, environmental factors are important because this is a disease of change of lifestyle, diet, stress. How many people were there who were PCOS before? Okay, fine, it was not a diagnostic, it was not a diagnostic entity only before back then. But the junk food, urban lifestyle, less of exercise, is a very major contributor in the development. It's actually a metabolic syndrome. I will be discussing about this metabolic syndrome towards the end of this discussion. But that just shows that this urban lifestyle has got definitely something to do with the development of PCOS. Like I said, it's a multifactorial polygenic factor. So in a nutshell, PCOS caused by insulin resistance. In hyperinsulinemia, these things are happening. There is more of an androgen production. There is decreased progesterone. There is ovulation. There is more of LH, less of FSH, increased estrogens. And with chronic inflammation, it causes long-term complications of PCOS like dyslipidemia, diabetes, cardiovascular disease, and endometrial carcinoma.